Good afternoon. Why don't we get started? My name is Tom Stelfox, as Scientific Director of the O'Brien Institute for Public Health. I want to offer you a warm welcome to everyone joining us today for today's webinar, Our Health System on Life Support, Strategies for Reform. Before we begin, I'd like to acknowledge the land from which we are holding today's event and to honor the first peoples who cared for and celebrated this land since time immemorial, and now share this land today known as Southern Alberta. So most of us are gathered on the traditional territories of the people of the Treaty 7 region in Southern Alberta, which includes the Blackfoot Confederacy, which includes Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. The city of Calgary is home to Métis Nation Alberta Region 3. Let me just say at the outset that there's nowhere else I'd rather be today than right here with you to have a conversation about health system reform. You can't open a newspaper or a social media website today without reading about the strains of our health systems. At the O'Brien Institute, 2 years ago, we recognized that once the pandemic stabilized, there was going to be an urgent need for health system reform. We knew this because of baseline trends in the health system, as well as lessons learned from Ontario when they experienced SARS-CoV-1, which was a much smaller sort of health system impact. And it was clear to us that our health systems would not be sustainable. And so what we did in preparation for this is we launched an initiative to explore policy options for reform. What we did not anticipate was just how big and emergent a problem this would be. And this is why we're so fortunate to have such a wonderful lineup of panelists for you today. These are people who've been leading the Center for Health Policy's Health System Sustainability Initiative at the Institute. And so let me briefly orient you to our agenda. We've got 4 panelists. Each is going to provide a 6 to 7 minute summary of the key findings from the work they've been doing for the last couple of years. This will be then followed by discussion and Q&A. The discussion is meant to be interactive. I know that's more challenging when we're in a virtual setting like this. So please put your questions in the Q&A box. And with over 150 people registered for today's event, we're not going to get to everyone's questions. What we'll do is we'll try and focus on those that are being asked most frequently. I think this is going to be a super exciting hour. Please participate and enjoy the discussion and debate. So to get us started, let me introduce the 4 panelists. We've got Dr. Clement, who is head of the Department of Community Health Sciences here at the Cummings School of Medicine and the University of Calgary. She's an expert on health system reform and will share with us what Canada can learn from other countries. We have Raquel Drummond, who holds a Master's of Public Policy and is a research associate with the O'Brien Institute. She's an expert in policy writing and will share with us learnings from an examination of Canada's many health system commissions. We have Dr. Moss, a Banting postdoctoral fellow at Dalhousie University and the University of Pittsburgh. She's an expert in citizen partnered research and is going to share with us what changes to Medicare Canadians are telling us they want to see. And then we've got Dr. Quinn, co-director of the Health Policy Trials Unit at the O'Brien Institute Center for Health Policy. She's an expert on health system funding models and will explore potential priorities for health system reform. So I'd like to invite Dr. Clement to get us started. Welcome, Dr. Clement, and thank you for joining us.
Thank you, Tom. I'm excited to be here. And I wanted to open with a tremendous thank you to the team behind this work, many of whom you'll hear from today. So we did 2 different pieces of work. The first was a literature review asking the question of what structural health reforms have been undertaken in other countries. And for this, we used the literature to create timelines for the structural reforms for each OECD nation. We then next went back to the literature and did a concept analysis looking at what made reforms work or didn't work so that the reform actually occurred in the system. We grounded our work in a conceptual framework that's been developed by the World Health Organization, and we needed to adapt a little bit, but this is a common framework used to describe different healthcare systems across 5 dimensions. So financing, who's paying, population coverage, who's in, governance, who's making the decisions, who's delivering the services, and what kinds of services are covered for people. So jumping right into our findings, because that's the most interesting part, we did across these 5 different domains find that reform was continual and very often in most healthcare systems. Notably, Canada is an outlier in this area where our system has remained basically the same since it was developed in the 60s. I want to draw your attention to a particular changes across those 5 domains in the middle, and wanted to note that when we're talking about population coverage, all of the reforms in this area were taking steps towards universal coverage. So a system that would have health coverage for all of the people living within a certain geographic area. And for some systems like Canada, this was achieved with a really big bang change. So when we adopted Medicare, it was everybody in. In other systems, this has been much more sequential, which might help explain some of the difference in the volume or the number of reforms that other systems have gone through in comparison to Canada. Switching over to service delivery, I'd like to highlight that many of the systems have gone through lots of reform here as well. Often the systems would start with some kind of not-for-profit system. So either a poor fund is a common descriptor, or some kind of charitable service delivery that was targeting people. And then they would evolve to develop public delivery arms as well as private delivery arms. And so most systems currently are a mix of public and private delivery. The last thing I'd like to draw your attention to on the dimensions is the service coverage. So almost all systems started with a focus on hospitals and physicians. And again, many of these systems have long legacies. So if you think back to what healthcare might have looked like in the 1960s or earlier, those were really the critical services for illnesses that people were experiencing. From there, most systems have expanded out to include some outpatient services, allied health professionals, and different kinds of mental health services as they expand out. Other systems have also expanded out to include things like dental care, vision care, pharmaceutical coverage, which are important components of healthcare service delivery. And just hearing that list, you might realize that Canada had stopped quite early in that service coverage expansion, where we don't have things like dental care, vision care, pharmaceutical care, strong mental health coverage in many of our different aspects of the system. So what has been driving all of these changes? We identified 3 different factors that were the prime drivers behind reforms. The first being economic crises. And so really here we saw an economic crisis driving many financing and governance changes, with often when an economic crisis was happening, shifting payments from the public sector, either directly onto patients or bringing in stronger private insurance models. And in the governance sector, again, decentralizing was a common response to an economic crisis. So shifting responsibility for the system from a highly centralized mechanism down to smaller levels of government or other actors in the system. Paired with that, often political changes were big drivers. So you would see a newly elected or a newly acclaimed government coming in who wanted to make sweeping change to the healthcare system. And that was often a big driver of changes about how the system was structured. And then our third driver was population needs. And so here you might think about things like an aging population, for example, or the shift from a primarily acute care kind of disease model into a more chronic disease model. And these things driving the system to redesign to better meet the needs of the populations. So what is the process through which a reform happens? Through this literature concept synthesis, we were able to identify this kind of structural model that explained why reforms occurred or didn't occur in different contexts. So the first, of course, was identifying the reform intention. It then goes into this process where we identified 4 thematic elements, including the idea that best laid plans didn't always go as the plan was intended, and that there needed to be some flexibility and responsiveness to the process, that the context was crucial. So what was happening, why it was happening now, and when the window opened was crucial to whether the reform actually occurred or not. Stakeholder interests is the recognition that the process of reform is a fundamentally people-focused process, and the different people who are involved or not involved in the reform greatly influenced whether the reform actually happened or not. And then the final piece was really around evaluation. So in many of the papers that we identified, they actually weren't sure if the reform had happened or not, because they weren't actually sure how to evaluate whether something had occurred or not. And then moving through all of this process, the reform would come out the other end. And it was important to note that this process was really like a mold. So the reform coming in might look quite different than the reform coming out as it moved through this heavily context and stakeholder and plan-driven process of reform. So bringing this all together, what are the findings that I wanted to share with you today? First, that health system evolution internationally has been continual in many nations, that the drivers of reform that I noted, so economic crises, political changes, and population needs, mirror the context of today. And finally, that the process of reform is a responsive and adaptive process that often molds the reform into a change or a structural change that looks quite different than what might have been envisioned boldly at the beginning of the process. Thank you. I'll turn it over.
Awesome. Thanks so much, Fiona. So first of all, good afternoon, everyone, and thank you so much for taking the time out of your day to be at this webinar with us. As you've heard so far, and I'm sure you're very aware, we're at a very exciting and formative time for healthcare reform in Canada. So your presence here today is a huge part of that. As Tom mentioned, my name is Rochelle, and I'll be presenting on implementation and advice giving, specifically in the role of federal advisory bodies in Canada. So I'll first just begin with a little overview of the aims and methods that our team took within this research. So there was two overarching research aims. The first included examining the role of these advisory bodies in federal health policy since 1990. And then the second was to describe how these advisory bodies influence policy implementation using these federal health reports. So in order to achieve these aims, we had a couple different research methods that we used. The first was to do a complete analysis of 5 identified federal advisory reports, as well as the context behind them in terms of the government and what was happening in the world at that time. So this just kind of gave us an in-depth understanding of the reports and their recommendations themselves. Following this, we conducted 12 60-minute one-on-one interviews over Zoom with members and implementers of federal advisory bodies on health system design, again, since 1990. So these interviews largely aimed to explore the goals and processes involved in these advisory bodies, while also trying to figure out what facilitators and barriers there may have been towards the implementation of their recommendations. So participants were gathered through purposive and snowball sampling as a means of gathering a more approximate level of all of these reports. And then following these interviews, we uploaded all of our transcripts into in vivo tel software and used a reflexive thematic analysis to analyze our data. So in turning to our first finding, it was more so surrounding success or failure. So overall, we found that participants had several interpretations of which reports were deemed as successes, which were failures, and why that may have been. So as displayed in this first quote here that reads, "I'm disappointed in how little concrete change there was. 20 years later, we are still having the same conversations." This was a sentiment that was largely shared by many participants. Participants often noted that, despite the government's initial recommendation for this report, extensive research and high levels of consultation, many of the recommendations that they have brought forward historically still remain stagnant, despite these ongoing conversations. As we will discuss momentarily, these failures were often linked with conflict amongst and between various levels of government, as well as with Canadians. In the second quote, we kind of see an opposing perspective. This quote reads, "Most significant changes take a while, and it always takes another generation to take it on because the generation before made a whole pile of noise and arguments, but couldn't get it through to the next generation." So within this quote, this participant largely saw ongoing repetitive generational recommendations as small stepping stones to achieve a larger goal over time. So more of a collective approach. Further difficulties in defining the success or failure, we found that when all these recommendations are the same over time, it's difficult to pinpoint who is responsible for success. If it was one recommendation from a report that was deemed successful, or if it was this collective success over time. So overall, while success is difficult to identify, it is important to note that all of these reports have contributed to a growing pool of literature and the ideas for health system reform that are so important today. In turning to our second finding, we're speaking specifically to high levels of conflict as identified as the largest barrier of implementation. So as depicted by this little pyramid chart here, conflict mainly existed in 3 distinct categories. On the base of the pyramid, conflict between the provinces and territories with the federal government was the most commonly discussed source of conflict within the interviews. So this conflict largely arose not necessarily due to misalignment in goals, but more so a lack of trust between these levels of government. This trust was historically stemming from significant periods of financial cutback, lack of cooperation, and just the overall perspective that perhaps the federal government is not following through on the promises that they have been making to the provinces. So moving up a tier, we're now speaking to the conflict between the internal federal government. So within those bodies, this was the second most commonly discussed level of conflict within our interviews. This largely resided due to internal departmental conflict, agenda priorities, and the defined roles and responsibilities. The final tier, which some of you may resonate with, was conflict between the federal government and Canadians. This was the least commonly talked about type of conflict in our interviews, but as we can see, maybe on your own personal level or in the news, Canadians are quite upset with the federal government. This conflict largely resided in mistrust of the government to do what is best for Canadians overall, and again, to follow through on their promises. This conflict was also largely due to the value that Canadians place in our current healthcare system and the feeling of a threat if the healthcare system was to change to a different system. So overall, the results of the interview found that conflict amongst these 3 levels was largely a result of inaction, mistrust, and values. For our third finding, findings from our interview revealed that advisory board members are, 1, not mandated to implement the proposed recommendations from the reports, and 2, are often not given the power to do so. When asking participants about the role of implementation and why this is not mandated, one participant stated specifically that the government itself does not necessarily want this level of scrutiny because they would rarely implement all of the recommendations of the reports. So it's not exactly in their best interest to have someone pointing out that they only implemented a 10th of the recommendations in their reports. Besides this, all of the advisory bodies took tremendous efforts to engage with and consult with the various levels of government and the public. Efforts to engage with provinces and territories specifically while writing the report included consultation and coalition building. With the exception of those who had personal relationships that could be continued outside of these conversations, largely once the advisory bodies concluded, there was no discussions further on consultation on how the report was moving forward. Implementation strategies utilized by advisory groups with the federal government included having designated staff roles, such as assigning an intergovernmental officer in the Romano report, as well as collaboration amongst several departments, such as the finance department. These strategies largely allowed for expert consultation amongst other departments and accountability through having these assigned roles. And lastly, all participants noted the public as an important and invaluable part of the implementation process, both during and after the publishing of the report. Efforts to engage Canadians while writing the report often included engagements and presentations, often in the form of town halls. And following the publication of the reports, several formal advisory body members took it upon themselves as their own individual effort to disseminate the report to the public by presentations, speaking to the media, and publishing follow-up reports. So what exactly does this all mean? Our main takeaway from this research is that federal advisory groups should be given a more explicit role in the implementation process. Coalition building in itself has the potential to bring expertise, to reduce ambiguity in policy recommendations and the implementation process. As seen throughout the reports, Coalition has served as an important tool to gather unique perspectives to create reports. Those same unique perspectives and skill sets can serve as an asset in implementation of complex and sensitive policy recommendations. In looking towards implementation plans as an option, they truly have the potential to increase this accountability that we're lacking and the transparency in the government, while reducing conflict by identifying timelines, goals, or clearly identified roles and responsibilities. And lastly, evaluation mechanisms. Efforts made to evaluate advisory bodies has historically been taken on by individual efforts, as we had seen previously, and other analysts rather than as a mandated process. By having this mandated, we have the potential to increase accountability for recommendation implementation while allowing for review and improvement of the process. Altogether, coalition building, implementation plans, and evaluation can help to foster a stronger sense of accountability and transparency within the government, while reducing conflict and building trust between all levels of government and Canadians. Thank you, and I will now turn it over.
Thanks so much, Rochelle, and to all of the attendees who are here today. As Rochelle mentioned, your presence and participation in this discussion is crucial as we shape the future of our healthcare system. So for my portion of this webinar, I will present on stakeholder perceptions of the Canadian healthcare system. So my co-panelists have set me up very well with their earlier introduction, so it comes as no surprise when I say that reform to the Canadian healthcare system is essential to develop a higher performing system that addresses the multifaceted nature of efficiency, sustainability, and implementation challenges. So for this study, the objective was to develop a deeper understanding of the views of Canadian stakeholders on structural and process deficiencies and strategies to substantially and meaningfully improve the Canadian healthcare system for enhanced population health outcomes. To do this, we employed a qualitative descriptive study design using semi-structured interviews, and we used existing contacts from our professional networks, as well as social media recruitment and contact information that was available on professional websites. And we used these sources to recruit one man and one woman from 5 regions in Canada across 4 broadly defined stakeholder groups that included public citizens, healthcare leaders, researchers, and academics, as well as political decision makers. We used Donna Bedian's model that included the 3 main components of structure, process, and outcomes as the underpinning conceptual framework for this project. Overall, we interviewed 31 stakeholders across Canada that included 13 public citizens, 10 healthcare leaders, 4 academics, and 4 political decision makers. And this figure here illustrates the thematic findings from our qualitative analysis that I will walk us through now. So to start, up on our top left, we have the common structural problems that stakeholders identified as they related to the Canadian healthcare system. Nearly all of the 31 participants in our study perceived the current healthcare system in Canada to be a sick care system. That is, the system waits for an individual to become sick before it actually kicks into reactive action. And participants almost commented on how, for the most part, the system was not designed to help prevent the onset of disease, but instead to diagnose and treat illness after it occurs. Many participants also reflected that the Canadian healthcare system is deeply ingrained within the Canadian identity, challenging potential for any future reform. We then heard from participants as they debated private versus public healthcare funding, and we heard a general voice of discomfort whenever privatization was brought up. While some participants felt that private care might lessen the load on healthcare services, others feared it would threaten equity and accessibility of care. So moving over to the right, we'll talk about how Canadian stakeholders in our sample commented on 3 process problems for healthcare delivery. Staffing shortages were unanimously recognized as a pressing and persistent problem. Workforce shortages were recognized and felt across the broader healthcare system, from hospitals to home and community care, long-term care, as well as primary care. And this really resulted in low staff to patient ratios and high overall workloads. Many participants described concerns regarding efficiency of the healthcare system, in particular, the duration of time that's often required to see a healthcare professional. Inconsistent care was the third sentiment held commonly across stakeholders, and coverage across provincial health authorities, especially for chronic illnesses, was a common point of confusion. Third, at the bottom of that figure, we can see that stakeholders provided actionable opportunities to improve health outcomes. They commented on how clearly delineating roles and defining the scope of practice to minimize redundancies and maximize expertise, as well as perhaps revising incentives at the point of hire might be a potential opportunity to explore. Public awareness and overall health literacy was then discussed as a defining factor for the future of the Canadian healthcare system. Healthcare leaders and decision makers in particular suggested that enhanced public understanding of health policies, including their short and long-term impacts, might facilitate a more effective public voting power in the future. And finally, many participants underscored the importance of shifting the focus of our current healthcare system toward preventative care. They suggested that greater focus on interdisciplinary collaboration and community-based care could help to achieve this. So these findings highlight that Canadians overall are very well aware of the signs of healthcare system distress across all jurisdictions, as they noted varied structural problems as well as problems with the delivery of care. A defining feature of our future will be that the Canadian identity is deeply entwined within our healthcare system, which can show up as protectiveness towards our public system, potentially prohibiting change. And ultimately, this relationship must be studied, understood, and better unpacked to facilitate effective approaches to enhance broad health literacy so that we can move forward as a country. And finally, as we've heard many times today, Canadians are calling for action. We have a population that is ready for change. However, there is no silver bullet for a crisis that is decades in the making.
Thanks so much, Stefana, and everyone else for what you've contributed so far today. I'm going to be talking about our last project, which kind of pulls all this stuff together, called A North Star Vision: Results from a Deliberative Dialogue to Identify Policy Strategies to Improve Value of Care. So what we did for this project was we hosted a deliberative dialogue with a group of citizens, policy researchers, government decision makers, and health system leaders, with the goal of identifying evidence-informed policy options that could improve the value of Canadian healthcare. So by value, I mean like the performance that we're getting for the amount of money that we're putting into the system. So what a deliberative dialogue is a group process that's informed by research evidence. So our group that you see in the picture here heard the presentations that you just heard, and then we had facilitated conversations with the goal of bringing together the research evidence and the participants' knowledge and experiences and values, and to really try to create a consensus around what strategies are needed to move forward with Canadian healthcare reform. So the results that we heard three main themes during this deliberative dialogue. And the first theme that we heard was that we need to get to the healthcare system of the future, but we need a vision to guide us there. So the 5 priority areas for reform that were identified that we need in this health system of the future are having this vision that guides our reforms. And the quadruple aim was suggested as that vision. Leadership, we also need leadership to get us there. So there were different leadership roles for both the federal government, provincial governments, and also territorial governments, and then local communities as well were discussed. We also discussed the need for an expansion of services, be that more dental coverage, which has been discussed federally lately, as well as potentially using community and volunteer resources more efficiently to help reach a broader population. Another thing that was discussed was the need for using our healthcare dollars more effectively and efficiently in order to drive change. And lastly, we talked about the need for new models of care. So the new models of care that were discussed lead us to our second theme, which is that we need these new models of care, but we need the care to be focused on care in the community rather than the institutional settings that Canada has primarily reimbursed care, such as hospitals or continuing care facilities. So we need to think about primary care and thinking about reforms that we could have public delivery that would go alongside the private delivery system that we have now. We talked about public health interventions that could be part of primary care to help address social determinants of health. And this also included discussion about the need to expand mental health and addiction services and have them be more part of the healthcare system. And then lastly, there was a lot of discussion around improving care for seniors and allowing them, focusing on care delivered in the home and allowing them to age in their home. Similarly, there was also talk about hospital care being able to be delivered in the home rather than only in hospital. And then, so the last thing that we identified was that in order to overcome these barriers to change that you've heard a lot about today, we really need to have community engagement in care. So these strategies talked about a shift in some decision-making and control towards community that might start to address those structural considerations of power and voice within health systems. So some strategies that could really do this are non-tokenistic roles for citizens in decision-making bodies, such as in governments and delivery systems, having conversations with patients and citizens, both as a way to create a narrative around this need for reform, like you just heard Dr. Moss talk about today, or also as a way to create sort of a reporting mechanism to identify where performance needs to be improved. There was also discussion of the need for public education about the healthcare system and also public reporting of healthcare system performance. So pulling all of this together, what we really saw as the North Star vision to get us to the healthcare system of the future is this new paradigm of community-focused health systems. And this would include care in the community and engaging the community in reform and delivery. So 3 strategies to get us there would include engaging citizens as co-designers and co-leaders of healthcare systems, reorienting our health system toward primary and community-based care across the lifespan, and implement supportive structural reforms that include accountability mechanisms and public reporting. So putting all of that together that you just heard, which was again like high level across all of these, we identified 3 recommendations for healthcare reform in Canada. First, we want to think about engaging all of the players. So that means, it's clear that big changes are needed to get our system off life support and improve the value of care. So how do we need to engage communities in this, payers, providers, patients, and we all need to work together to design these reforms. And we need to remember, we need to explicitly address how Canadian identity is intertwined with Medicare, and this being a historic barrier to change. Secondly, we need to think about reorienting the system to primary and community-based care. And by prioritizing these types of services, we can reduce costs of institutional care and hopefully improve access and quality. And then the organization and governance of primary care, as well as expanded coverage of services like dental care and mental health care, are important considerations in this area. And lastly, we need to think about being adaptable and accountable. So the system is stuck essentially in like what our Canadians' needs were in the 1960s, but we need a system that's responsive to our needs now. And then, as Dr. Clement talked about, reforms are often very adaptive. So as we are thinking about making recommendations and implementing reforms, we need to remember to be flexible, and particularly to the diversity of needs across all of the different provincial and territorial healthcare systems that we have in Canada. And lastly, we know the Canadians want action, and they deserve to know how the reforms are improving the system and if their tax dollars are contributing to improved performance and value of care. Thank you very much.
Great. Thank you, Drs. Clement, Drummond, Moss, and Quinn. So I think what we can do is probably drop the slides and then just go to a bit of a discussion. So I'll ask people to put questions in the Q&A, and then Brenly Farkas has very kindly agreed to collate those because I'm not technologically sophisticated enough to moderate and monitor the chat at the same time. But I'm going to take the prerogative and start us off with a question while we wait for questions to come in. So as I was listening to the presentations, what I heard is that we've got data from around the world that tells us roughly what we think will happen with given policy changes. We've got decades of reports that have looked at the Canadian context, and we've got a population that says we would like change. So to me, this sounds in a very basic way like we've got our ducks all in a row. And so the question that I've got for our panel is, unless I'm missing it, why are we not seeing change? Maybe what I'll do is I'll ask Fiona, I'm going to go to first names now for simplicity. Fiona, do you mind sort of maybe helping us launch into answering some of these questions?
Thanks, Tom, and thanks for starting off with an easy one. I appreciate that. I mean, I agree with you. I think our ducks are in a row and have been for some time. And so I feel the biggest barrier for us moving forward has been the federal, provincial, jurisdictional challenge. And just like, healthcare is often talked about as the third rail in the political realm. It's just too charged for there to be a collaborative action and it has to be in sync between the provinces and the feds to really move forward the kind of structural reform that we deserve and we need to be seeing right now. So to me, that's the barrier, and that's why we haven't seen these big changes that we need.
Okay, I'm going to ask Rochelle, you went through all those federal reports and spoke to all those people, and I can't imagine how painful that was, to be honest, the reports. Obviously, they're important, but any lessons from that as to why we're so stuck?
Yeah, thank you, Tom. And it wasn't as painful as you would think. It was nice to get the context. I will largely echo and kind of add on to what Fiona was saying, and I guess kind of the main point in our presentation. Amity and I worked on this together, and conflict was amongst the feds and the provinces was such a huge issue. It's historically continuing where we're having this mashup of relationships and things aren't moving forward just because of lack of trust. Back in the Chrétien era, from these reports, we kind of saw, this step back to kind of look at these reports and see, okay, we're missing this trust right now, and we have to build that back up after, years of financial cutbacks. So then we kind of started to see a little bit of momentum in healthcare reform. But it wasn't without that step back of realizing we need to mend these relationships and build back that trust before we can move forward. We're largely seeing that today, with the NDP deal with the Liberals and trying to build back that trust. And hopefully that will be an important stepping stone in reform as we're going forward. But, those agreements need to be followed through on. That's a huge piece as well, is that even if we have this little bit of trust and, these agreements, actions need to be put to words. Thank you, Tom.
Great, thanks, Rochelle. I see questions coming in now. Before I get to them, I'm just going to ask a follow-up. Maybe I'll direct to Stefana. So we heard about conflict and trust. You spoke to Canadians representing, some of them in clear health roles and others that were citizens. There's over 120 of us here on this call today. What can we do to try and promote thoughtful and meaningful system reform, right? So what role can actual regular Canadians do?
Well, for us regular Canadians, we can help to move our system forward by having open conversations with friends and family about reform and the role of voters to enact change. Increased public understanding on current governance structures of healthcare will be critical, I think, to garner support for any sort of substantial reform. So as individuals, we can bolster our own understanding of the Canadian healthcare system by starting to use evidence-based information. This will allow us to advocate for change by voting for political powers that will shape our healthcare system into a more equitable and accessible system. So I really encourage everyone on this call to think critically about political promises regarding healthcare and to try to hold politicians accountable for past promises, sharing evidence-informed content among our networks and encouraging others to assess the value in long-term versus short-term solutions to healthcare issues will really serve us well as we move forward. So really having those open conversations and increasing our health literacy is something that we can all do moving forward.
Great, thanks, Stefana. So I see multiple questions coming in around financing and around today's, as many of us know, the Prime Minister is hosting a First Ministers meeting today in Ottawa to work towards a deal with provinces on healthcare funding. We talk lots about funding. And so my question then is more money the solution? And maybe what I'll do is I'm going to go to Fiona first, and then I'm going to come to Amity, and then whoever else wants to comment on that.
Thanks, Tom. So I want to say just a couple of things on this. So first of all, I don't think more money is the solution. I do think perhaps the split between the feds and the provinces for the total bill, that is the bill today, it could be fixed and adjusted, which my stance would be if the feds increased their contributions, allowing the provinces to extract some of the funding they have allocated. Across the provinces, the Canadian average is that the provincial budgets, about 37% are going to healthcare. In Alberta, it's higher, it's around 40%. That's a lot of a provincial budget to one portfolio, recognizing how important that portfolio is, but thinking about the many, many, many things that contribute to health and well-being in a society. Many are not in that healthcare budget. So I do think the split could be adjusted more towards the feds. But when you're looking at how much Canada spends, so we spend second most amongst the OECD nations for our healthcare system, and we don't have the best performance. We don't have the second best. We're really middle tier in terms of performance. So that says to me that other places are able to deliver higher performing healthcare, get better outcomes for less investment than we do. So that says to me that actually money isn't the problem. So that's my stance. And I also just wanted to make a plug for, today is fantastic for the feds to sit down with the provinces again. But I do just want to harken back to us talking about the system being in stasis, which COVID taught us, through my lens at least, that state of stasis is self-imposed. When COVID hit, we saw things that had been on the docket for many, many years happen in a matter of weeks to respond. So, and we also saw the feds and the provinces sitting down sometimes on a weekly basis to solve problems. So I do think that the state of stasis that we found ourselves in is completely self-imposed. And I hope that today is a really productive step forward.
Great. Thanks, Fiona. Amity, any thoughts on this issue of whether more money is the solution?
Yeah, I think I largely agree with Fiona that I think the federal government increasing the amount they're contributing, I think actually could be a valuable part of the solution, because as Rochelle has talked about, that the federal government had when Medicare was set up, agreed to pay a 50-50 split with the provinces, and then they retracted that, and now it's in the high 20s. So it's debated how much they're actually contributing. But I think if the federal government was contributing more money, then that could help restore that trust that Rochelle talked a lot about, and help sort of restore the federal government as a leader in the healthcare space. But yeah, if provinces were able to reallocate some of their funding to other social services programs, that would, or other needs of the provinces, that would be great. I would also say, like, one of the things being discussed today is like increasing, like, should there be strings attached to the additional money? And I think that I would say yes, there definitely should be strings attached. The ones that are out in the news right now as being discussed, like one of them includes more data, and like I think that's an important step, but like we can't only collect the data, we need to do stuff with that data. We need to measure the performance that Fiona had mentioned. We're not performing well, like we need to be documenting that and reporting that and trying to improve that.
Great, thanks, Amity. So some of the questions coming in are about where should the priorities be? And in the discussion, there was talk about community-centered or community-focused care. We've got questions in the chat about, should primary care be the focus? We hear lots about long waits for procedures, right? Surgical wait lists. We hear shortage around health workers. We also hear around high costs for care, particularly as interest rates are going up. And so maybe I'll ask you, Stefana, if you can start on this question. If we had to focus, if we have more than one priority, we could say we don't have priorities. If there's one thing that we needed to focus on to start off with, what would that be based on what Canadians were telling you?
Yeah, well, what $1 million question, hey? And as I mentioned in the conclusions for my presentation, I really wish there was a silver bullet that could come in and fix our healthcare system, but we don't have that yet. So based on the perceptions and experiences of the Canadian stakeholders that we talk to, there seemed to be a relative sense of urgency specifically regarding staffing shortages as it related to family practitioners or general practitioners. We found that when we looked a little bit back into the literature, we found that previous research had identified that incentives such as preferential selection of rural students to fill gaps in rural locations, or inclusive management strategies and educational and professional development opportunities might be some strategies to help to fill those gaps in the relative staffing shortage in family practitioners. There was another point. I know you wanted me to mention just one, but another common theme that was really echoed by Canadian stakeholders was a long-term investment with regard to preventative care. So a system that really focuses on interdisciplinary collaboration and community-based care that has shared electronic medical records and information systems, as Amity mentioned. So the lack of the national centralized information system was perceived as another really big gap in our healthcare system right now. So improving workforce data collection would be something that's an area in need of really crucial investment.
Great, thanks, Stefana. Rochelle, from your interactions with the reports, is there anything in those reports that we've consistently failed to deliver on that maybe should be a top priority for reform now?
Yeah, for sure, Tom. There's been countless recommendations, rather large ones that have gone unanswered. I know the largest one that all of us think about right away is pharmacare. That has been in some way or another, whether it's accidental drug coverage or any of those measures associated with pharmacare have been recommended since 1990. And as we have seen, it's not largely implemented yet. So that, and plain and simple, is what I would say is what is continually being recommended and not going forward. This is a wicked problem in itself that has, been taking this time, and there is large barriers to it if after all of these recommendations, they are still not going forward. We have seen some shift in the government lately with that deal with dental coverage, but it is still not going forward. I don't think that this is largely due to conflict amongst Canadians and the government. I think overall this is a very wanted policy on Canadian side. I think the shift is largely between the federal government and provinces, tying back again to funding and where the responsibilities lie with implementing pharmacare and where the money's going to come from. As Amity mentioned, the specific ties associated to going forward with this plan and how that accountability mechanism is going to be in place.
Thanks, Rochelle. I'm got clearly way more questions I'm going to get to. I'm probably going to get to two more questions. One of the ones that I've seen pop up here is someone has said that, every time we talk about health system reform, the issue of private versus public health care gets raised, right? And we heard a little bit about the fact that Canadians strongly identify with their healthcare system, and that this has maybe constrained our ability to make some of the changes that may or may not be helpful. And so maybe I'll ask you, Fiona, to start off. Can you provide any guidance for how Canadians can think about the issue of private versus public? And I'm purposely leaving it very broad the way I've asked that of you.
Mm-hmm. Yeah, so I just wanted to step back for a moment and clarify a little bit about the two different parts of the system. So I think often when we're talking about private healthcare, we might be talking about private payment, meaning, a patient would go into the hospital and whip their credit card out afterwards and pay for the episode of care out of their own pocket, perhaps reimbursed by insurance at a later date, versus the way it is now where healthcare is publicly paid for. So there's that payment side of it. On the other side of it is delivery. So public delivery versus private delivery. And I think often we don't separate the two issues, and they are completely different issues with completely different impacts on our system. So I will just note, like, private pay, my own personal opinion is, like, I will fight till my dying breath to keep private pay out of our system. It is inequitable. It leads to barriers to access both appropriate and inappropriate care, really detracts from our vision of universal health care. So my own opinion is that we should, again, till our dying breath, keep that door closed. On the private delivery side, we already have many, many aspects of our healthcare system that are delivered privately. For example, primary care. The vast majority of primary care clinics are private businesses run by a single primary doctor, multiple doctors aligning themselves together. And so I do think having a discussion about where, how, and what the accountability framework is for private delivery in our system could be a discussion that we could have as we move forward.
Great, thanks, Fiona. Amity, can you comment a little bit when we think about remuneration? We've had some questions about physician remuneration. This is an area that you've got expertise in. Should we be changing how we pay our healthcare providers if we're going to reform the system and seek the advances we're seeking to find?
I don't think there's a silver bullet for this either, because it really depends on which type of physicians we're talking about and where they're practicing. But for this model of care that's been discussed today, that's very primary care based, community care based, and team care based, like that is not well served by the fee for service system that we have in place today. There have been, so I would suggest, if we want to have this kind of new vision and collaborative team based primary care, it would serve us to move towards payment models that support that. So would that be paying for potentially a year of someone's care, like a capitated model where you pay a physician a set amount per number of patients they are seeing, for example, or you have some, you could also consider paying for staff, like other kinds of staff to be working in their clinic, like a therapist. So you could deliver co-located mental health treatment, for example. So, and there are models like this that have, there's been some tested in Alberta, they're more common in Ontario, and there's been some other primary care payment models in Quebec that have shown to be effective, but there still has been challenges in scaling them up or having them lead to improved value or performance improvements. But I think that is a lot of that is tied up in the accountability, which Fiona just mentioned as well. So even though we're changing the payment, if we're not changing what the expectations or governance are of what we're getting out of that payment, then we might not see changes.
Great, thanks, Amity. Okay, I'm cognizant of time here, so I think we've got time for one last question. So a question that I've seen here, it's coming back to today's meeting from the Prime Minister and the First Ministers. The question is, what advice would you give the Prime Minister and premiers as they meet to try and get this right? And so I'll give each of you sort of maybe 30 seconds to provide a suggestion. And why don't we start with Rochelle?
Perfect. Yeah, that's a loaded question. I guess, as cheesy as it sounds, I would invite them to be very transparent with each other, outlining their goals, their hesitations. They really need to, in like a psychological way, understand where each other is coming from in order to arrive at a plan. They need to hash out their worries, their conflicts. They need to talk about their end goals and really make sure they're on the same page. That's a very psychological, non-political approach, but those relationships need to be built, and that trust needs to be established before they can even talk about reaching their objectives.
Thanks, Rochelle. If we're going to do that, then we might be here a long time, but I think that's important. Stefana?
Yeah, thanks, Tom. Super great question. From my end, I would say that Canadians can see the signs of distress. They're well aware of where the healthcare system has gotten to. They want evidence-informed policies. They want strategic investments. They want improvement in their healthcare service outcomes. And ultimately, they understand, there's no easy Band-Aid solution to fix the problems that have taken decades to be built. But they're ready for change. They're calling for change, and Canadians want a seat at the table. They want their voices to be heard. They want to be involved in the process.
Great. Thank you, Stefana. Amity?
What I would say is, I understand why the group is specifically together, like who is in that group is meeting today, but if we're going to move forward the recommendations that come out of today, I think we need to really think about engaging for healthcare providers and patients in citizens in actually sort of designing and implementing those reforms.
Great, thanks, Emma. And we actually really haven't talked about providers at all in our conversation today, a whole other added level of complexity and importance. And Fiona, do you want to finish off with the final comment?
Thanks, Tom. So I would say, like, keep the end game in mind. I think today could provide a great opportunity for people to grandstand on their causes du jour. And I really think I would advise, like, stay focused on the mission of trying to improve healthcare for Canadians. We need to see some action here, and the grandstanding that could result from today really doesn't take us forward. So I would say stay in the room, keep talking, focus on the healthcare system for Canadians. And, you know, I know it's hard, like, leave the politics at the door and really focus on the end game.
Great, thank you. Thank you, Drs. Clement, Drummond, Moss, and Quinn. Great presentations, lots of conversation. We only got to a fraction of the questions, so I apologize for that. I certainly learned a lot. When I was listening to you present and answer, one thing jumped out at me, and that it seems to me, for me, the key message is the time for action is now. Our health systems are, based on ideas that are half a century old. They may have good concepts in them, but things are very different now in society now than when I was growing up as a kid, right? We heard about the fact that our identities are tied to healthcare, and that can make the change pretty scary. But we need to be brave. And to sort of quote, I think I'm going to get this right, the late John Lewis, who said, if not us, then who? If not now, then when, right? And so as citizens, scholars, health practitioners, and members of governments, businesses, and NGOs, we all need to push for change. And thank you for taking this on. Thank you to our panelists for sharing their time, expertise, and experience with us. Thank you to the Center for Health Policy and O'Brien Institute teams, Brenley Farkas, Brittany DeAngelis, Angie Taylor, and Leslie Campbell. They made today's event a reality. I want to put a quick plug in for our next event, which is May 2nd. It's titled Alberta 2023, Health System Challenges and Opportunities. It's an in-person event at the Calgary Library. We've got a wonderful panel that's going to talk about some of the key public health and health system challenges in Alberta and some of the opportunities in advance of the election. And topics that we'll cover will include primary care reform, how we think about getting care to people in rural and remote areas, mental health, long-term care, and the future of AHS. Please put it in your calendars and watch for future announcements. And finally, I want to thank all of you who have attended. We really appreciate everything you do to advance public health for Canadians and people around the world. If you have a moment, complete the survey evaluating today's event in the chat. It helps us improve. Wishing you all stay safe and be well.